head and neck vascular pathology beyond the basics.
بسم الله الرحمن الرحيم. Head and neck vascular cases are beyond routine reporting. When they appear, they test even experienced radiologists. So today we are going to step past the textbook examples and look at cases where subtle clues made the difference. حابة بس أقول لحضراتكم ليه أنا اخترت اسم التوك بتاعتي Beyond the Basics. As with all advances we have today, it's tempting to think that technology will solve the puzzle for us. But the truth is the beauty of radiology still lies in the basics. In subtle mural changes, in small hemorrhage pattern, in faint vascular clues that software may overlook. These are the key signs that can completely change a diagnosis and impact the management. Not because we are leaving the basics behind, but because we are going to see how mastering them and applying them in complex situations, making the difference between the adequate report and a transformative one. إن شاء الله هحط الحالات ديت الحمد لله رب العالمين أنا اشتغلتها كلها more or less وصلنا بإذن الله للدايجنوزيس. حطها في صورة interactive questions. مش الهدف قوي الأسئلة قد ما بعرض how to think أو إيه اللي جه في ذهني during reporting these cases. My first case is a 37-year-old male patient presented with deviation of tongue, hoarseness of voice, dysphagia, and severe headache. CT and the MRI of the oral cavity and the neck were reviewed. Which of the following statements are most appropriate? This abnormal signal in the pharyngeal constrictor muscles representing invasion by a tongue-based mass. The lesion represents an oropharyngeal mass infiltrating the epiglottis. The tongue is pushed to the right side by mass effect. The tongue deviates to the left side due to ipsilateral hypoglossal nerve palsy. The field of view should be extended to the skull base. What do you think? خلونا نشوف الحالة فيها إيه. This is the normal pharyngeal constrictor muscle, and these are abnormal constrictor, small in size, atrophic redundancy, and there is asymmetric oropharyngeal lumen due to the redundant left side wall and descent of the soft palate. So this is an indirect sign there is glossopharyngeal and proximal vagus nerve palsy. These are the denervation changes in the left hemitongue. There is abnormal high signal and faint enhancement, and these indicate there is hypoglossal nerve palsy. And these are the famous signs of left vocal cord palsy with medial tilt of arytenoid, widened laryngeal ventricle, secondary epiglottic fold, and this indicates vagus nerve palsy. So, back to our choices. The correct answers are the tongue deviates to the left side due to ipsilateral hypoglossal nerve palsy and the denervation, and the field of view should be extended to the skull base where 9th, 10th, and 12th cranial nerve run closely and can be affected simultaneously. Here are more images for the same patient. Based on these findings, which of the following are correct? Please check all that apply. The appearance represents an enhancing skull base mass invading cranial nerves 9th, 10th, and 12th. It is a jugular paraganglioma with extension to the hypoglossal canal. It represents internal carotid artery dissection with intramural hematoma rather than a true neoplastic mass. It represents sigmoid sinus thrombosis with raised intracranial pressure. Angiographic study is essential for the definitive diagnosis. So what do you think? There is left jugular foramen mass lesion with concentric appearance and the peripheral hyperintense T1 signal. In the post-contrast and subtracted images, this peripheral hyperintensity disappeared, and there is central enhancing core. CT angiography confirms that there is concentric narrowing of the internal carotid artery. And the diagnosis is internal carotid artery dissection with intramural hematoma compressing the adjacent cranial nerves. So the correct answers, it is internal carotid artery dissection, and the angiographic study is essential for the definitive diagnosis. The take-home message of this case is that jugular foramen lesions are not always neoplastic. Vascular causes can present as a mass-like skull-base lesion. Carotid intramural hematoma is an imaging manifestation of carotid dissection, especially when an intimal flap is not visible. The key clue is crescentix or circumferential T1 hyperintense wall thickening with luminal narrowing rather than a discrete mass. Secondary denervation changes in muscle as tongue, pharynx, or larynx may mimic a mass lesion, and this is a classic pitfall. Always extend the field of view to cover the skull base and neck vessels when cranial neuropathies are present. My next case is a 54-year-old female patient with prior gamma knife reduced surgery for jugular paraganglioma. Now presents with left-sided headache, tinnitus, and progressive sensory neural hearing loss. MRI shows new leptomeningeal type of enhancement and vasogenic edema. Which of the following diagnostic possibilities should be considered in this clinical radiological context? This is true leptomeningeal metastasis from the paraganglioma. This is secondary dural AV fistula related to invaded or occluded sigmoid sinus producing venous congestion. This is venous hypertension related parenchymal edema simulating tumor infiltration. This is post-reduced surgery radiation necrosis with blood-brain barrier breakdown. This is infectious or inflammatory meningitis as TB or sarcoidosis as a non-neoplastic mimics. What do you think? Here is the left jugular paraganglioma and extending to the sigmoid sinus, displaying the same enhancement. Adjacent to it, there is left cerebellar leptomeningeal enhancement. On the contralateral side, the transverse sinus is congested with multiple venous collaterals surrounded with edema, and there is bilateral posterior cerebral hemisphere leptomeningeal enhancement. In the left temporal lobe, there is vasogenic edema in T2, no underlying contrast enhancement, and no gallium dotatate uptake. Other images for the patient shows other similar lesions in the oropharynx, in the left paravertebral, and in the carotid spaces. So back to our choices. Leptomeningeal metastasis is incorrect as it is very rare and it would show dotatate uptake. absence of the uptake makes this unlikely. Radiation necrosis is a classic delayed complication, but almost always occur within or adjacent to the irradiated field. The contralateral enhancement make post-irradiation necrosis very unlikely. Always infection or inflammatory meningitis is possible, but the specific laterality and venous distribution pattern should favor venous etiology over diffuse meningitis. So the correct answer, this is secondary dural AV fistula related to occluded sigmoid sinus producing venous congestion. And this is venous hypertension related parenchymal edema simulating tumor infiltration. More images for the same patient reveal multiple similar lesions in PET-CT with uptake. So the question now, is there such a thing as malignant paraganglioma? Yes, but the term malignant paraganglioma is only defined clinically and not histologically. Paraganglioma is defined as malignant only when spread to sites without normal paraganglionic tissue. Multiple tumors along the sympathetic or parasympathetic chain often represent multiple primaries and not metastasis. Without metastasis, all paraganglioma are regarded as benign regardless of the histology. But why not by histology? Histology alone cannot distinguish benign from malignant paraganglioma, as indolent tumor may show atypia and mitosis, while even blunt-looking lesion can metastasize. So the take-home message of this case is invasion or occlusion of the dural sinus by a tumor can produce dural AV fistula mimicking leptomeningeal metastasis. Venous hypertension can cause congestion and edema that mimics tumor on MRI, so please check venous outflow pathways. Malignant paraganglioma is defined only by metastasis to non-chromaffin sites, not by histology. And gallium dotatate PET-CT best detect paragangliomas and separate active disease from post-treatment changes. My next case is a 54-year-old male patient with neck stiffness and vertigo, was suspected clinically to have meningitis, underwent initial MRI and then follow-up CT brain 2 weeks later. Based on the provided MRI and CT images, which of the following considerations are most appropriate regarding this cisternal lesion? This is subacute blood with extracellular methemoglobin that can appear bright on T1, T2, and may lack blooming on SWI. In meningitis, BUS usually shows diffusion restriction, appear iso or hypointense on T1 without the high T1 signal seen in this case. SWI flow artifact typically dark, not bright, unlike here. And calcification typically shows blooming dark on SWI and hypertense on CT, which is absent here. The absence of hyperdensity on the CT is reliably excludes hemorrhage after 1 week. So what do you think? This is the normal marrow signal in the petrous apex, but there is abnormal signal in the prepontine cistern. It shows high T1 signal, some diffusion restriction, and predominantly high in SWI. This lesion is not seen in the CT study. Look to other images for the patient. There is hyper-enhancing nodule seen in the left internal auditory canal and enlarged feeder artery. This is the initial study, and this is a follow-up after 3 months for the same patient. there is a resolution of the prepontine cistern lesion, and only seen is the left internal auditory canal enhancing nodule and the prominent vessel. So back to our choices. This is subacute blood can appear bright T1, T2 and not showing blooming on SWI. This is correct. Bus was excluded in this case as it is ISO or low and not high as seen in this patient. Flow related artifact also was excluded as it should be dark on SWI and not high in this case. Calcification also was excluded. It should blooms and it should be hyperdense in CT. The only incorrect or false statement is the absence of hyperdensity on the CT reliably exclude hemorrhage after 1 week. As CT sensitivity decreases with time, late CT doesn't exclude prior hemorrhage. The final diagnostic confirmation for this patient was CSF sampling that ruled out meningitis, no infection marker and no pus. Follow-up MRI after 3 months later, complete resolution of the cisternal lesion, confirming it was blood and not persistent mass or pus. So finally, he was diagnosed as perimesencephalic subarachnoid hemorrhage complicating posterior fossa AVM. Early CT within 3 days is necessary for reliable assessment of the pattern of hemorrhage. Perimesencephalic subarachnoid hemorrhage often clears. More than 90% show no bleeding on the CT after 1 week. Redistribution and resorption of the blood can change the pattern of hemorrhage after a few days. The famous blooming of the blood on SWI occurred in acute or early subacute stage. Low signal due to strong paramagnetic effect is the cause of this blooming. Late subacute stage, as our case, shows high signal on SWI because of T1 shine-through effect, and the take-home message, not all bleeds are black on SWI. This is another patient. She was 69-year-old and presented with posterior fossa symptoms, underwent MRI, and to me the only finding was vague signal in the prepontine cistern. Looks like the CSF is inhomogeneous or not clear. But look to the contrast enhanced images, there is marked thickening of the dura mounting to mass effect in the prepontine cistern. And the final diagnosis for this patient was hypertrophic Becky meningitis after many investigation and the follow-up for her. So the take-home message of this case was perimesencephalic hemorrhage is usually venous and benign, but exclude underlying bleeder. Timing matters. CT may miss hemorrhage after 1 to 2 weeks, and thus MRI is more sensitive. Subacute blood can mimic mass as there is no blooming on SWI. CSF and the follow-up MRI confirm resolution and rule out persistent disease. Angiographic study is essential as it needed to reveal underlying AVM aneurysm or dural AV fistula. My last case is an 11-year-old male patient with history of ITP, idiopathic thrombocytopenic purpura, presented with right facial swelling of 1 month's duration. CT angiography was done. Which of the following statement about the mandibular mass in this setting is true? It represents a unilateral cherubism. It is due to repeated intraosseous hemorrhage and organization. It shows characteristic sunburst periosteal reaction suggesting telangiectatic osteosarcoma. Biopsy is always required to confirm the diagnosis. It's most commonly seen in patients with hemophilia. What do you think? Look to the pre-contrast CT. It shows an expansile mass with cortical disruption and thick bone septation. The arterial and venous phases of the angiographic study shows multiple contrast pooling that increases with time. The angiographic study shows no arterial feeder or tumor blush, but multiple vascular pools, and they're displaced rather than invaded arteries. So the diagnosis was intraosseous pseudotumor. Look to the differential diagnosis and possibilities. The first one is the osteogenic sarcoma. Telangiectatic osteosarcoma is an aggressive periosteal reaction and arterial blush in angiography, not seen in our case. The cherubism is a bilateral and multilocular expansile lesion of the mandible or maxilla. Our case is unilateral and the angiographic is not matching. This is a third patient for differential diagnosis. He was 22-year-old male and presented with left mandibular pulsatile swelling. Look to this patient. He has an expansile lytic mandibular mass, but there is extra osseous component with serpiginous subcutaneous vessels. The angiographic of the AVM was enlarged feeder, nidus of tangled vessels, and the early venous drainage, and the diagnostic hallmark was the arteriovenous shunting. So back to our choices, the correct answer it is due to repeated intraosseous hemorrhage and organization, and it is most commonly seen in patients with hemophilia. The pathogenesis of intraosseous pseudotumor is repeated intraosseous hemorrhage with organization and hematoma, and then expansile pseudotumor. It can mimic aggressive bone tumor, especially telangiectatic osteosarcoma or vascular malformation. Angiography really helps. It differentiates no arterial supply, no true tumor blush. The underlying bleeding disorder as ITB or hemophilia is a key to diagnosis. Avoid biopsy as there is high risk of bleeding, but multidisciplinary approach as radiology, hematology, and maxillofacial surgery. In this particular patient, endovascular embolization is useful to stabilize the lesion and prevent further expansion and allow safe surgery if needed. And finally, through this workshop, we have moved beyond the basics. Not just about knowing the vessels and their course, but also recognizing pathophysiology, variants, and the mimics. Not only looking at angiographic filling or contrast enhancement, but understanding hemodynamics, venous hypertension, steal phenomena, and the other. Imaging finding change over time as hemorrhage evolution or thrombosis stages. Choice of CT versus MRI versus angiography can make or break the diagnosis. Imaging alone is never enough, must correlate with history, symptoms, and multidisciplinary discussion. Thank you.
Thank you, Professor Tougan, for this brainstorming lecture. And now we